Welcome to a crash course in pediatrics. My name is Dr. Shahid. I'm a general pediatrician and medical educator. CRASH stands for Clinical Reasoning and Analytical Skills with Shahid. The goal of this course is to teach clinical reasoning skills to medical students and residents. This is a series of lectures that will take you through several pediatric cases where you will learn how to critically think through a patient case and come up with a broad differential diagnosis. These cases are intended for educational purposes only and are not intended for actual patient care. The objectives of the crash course are listed here. So let's start our case. In this case, we have a 6-year-old male with cough and trouble breathing. The patient is a known asthmatic who developed cough and shortness of breath 1 day ago. The mother gave him albuterol nebulizer treatments 3 times yesterday and twice so far today. He has had some improvement after the neb treatments, but is still having trouble breathing. There is no history of fevers, vomiting, or diarrhea. He denies runny nose, nasal congestion, or sore throat. He has had a daily productive cough for the past 2 months and wakes up about 3 to 4 times a week with coughing. Past medical history includes a diagnosis of asthma since 2 years of age. He has been hospitalized 2 times, both within the last year. He's had no ICU admissions, but has had numerous ER visits. His last asthma exacerbation was 3 weeks ago, for which he was managed as an outpatient and received prednisone for 5 days. The patient has been treated for ear infections, sinusitis, and pneumonia in the past. His medications include albuterol nebulizer or MDI as needed. He uses the albuterol almost every day of the week for the past 2 months. He uses Flovent twice a day and also uses hydrocortisone 1% cream for his occasional eczema flare-ups. Birth history was full-term normal delivery with no complications. Immunizations are up to date. He lives with his parents, a 2-year-old sister, and they have a cat. The father has a history of asthma as a child. The mother has hay fever, and the sister has eczema. On physical exam, his temperature is 37.3, heart rate of 112, respiratory rate of 32, a blood pressure of 104/72, and he is saturating 88% on room air. His height is 105 centimeters, which is the 3rd percentile, and his weight is 16 kilograms, which is also at the 3rd percentile. In general, he is a thin child who is in mild to moderate respiratory distress. On skin exam, he has some dry patches on his arms. His HENT is essentially normal, other than his throat having some slightly enlarged tonsils. On lung exam, he has subcostal and intercostal retractions that you can see. Air entry is decreased bilaterally. He has a prolonged I to E ratio, and also diffuse bilateral expiratory wheezing that you can hear. There are crackles that are heard over the right base as well. Cardiac is regular rate and rhythm with no murmurs. Abdomen is benign. Neuro is normal. And on extremities, he does have clubbing of the digits on his hands. To summarize our problem list, we have a 6-year-old male who has a history of moderate persistent asthma and eczema. He has been treated in the past for otitis media, sinusitis, and pneumonia. He has poor growth, and on exam, he has wheezing and crackles and a prolonged I to E ratio, and you also notice clubbing of his fingers. So in this case, we have a 6-year-old male coming in with chronic asthma that's gotten worse over the last several months to a year or 2. Recently, he's required more doses of oral steroids and is on daily controller medications, and despite that, he continues to have respiratory symptoms. He comes in acutely with some respiratory distress and some retractions, and on physical exam, he's found to have clubbing. In addition to the clubbing, he's also found to have poor weight gain and poor height, so overall poor growth. So this all leads to something more chronic going on. So this child has been diagnosed with asthma and difficult to control asthma. But one point to consider is that simple garden variety asthma does not give you clubbing. So this child does not just have simple garden variety asthma. He has something more going on top of his asthma. He might just have asthma, but there's something else going on that's causing him to have the clubbing and the poor weight gain. So when you see that in a patient with chronic respiratory symptoms and is being diagnosed as difficult to control asthma, but has clubbing, think about something else going on. And that's what we're going to talk about today, is the differential diagnosis of clubbing. So again, something more going on, and he could have asthma, but something else on top of it. So let's talk about just a little bit about what would be included on the differential diagnosis for clubbing. One of the things that you got to think about, especially in young kids, is going to be cardiac causes, right? So a child comes in and has clubbing, and that would imply that he has some chronic cyanosis, chronic hypoxia, and one of the cardiac things that you would think about is cyanotic heart disease that can lead to the clubbing. So cyanotic heart disease is something that you would consider in a child. Now, most likely he's 6 years of age, so he probably doesn't have cyanotic heart disease. It would have presented earlier in life, and he would have been found to be cyanotic and hypoxic and things. So it's probably not as likely in a 6-year-old child, but something that I guess you can consider in the differential of clubbing. In addition to that, you might also think about subacute bacterial endocarditis. So endocarditis also can give you clubbing, so that's something to consider on the differential as well. So those are probably some of the big kind of cardiac things you might think about. The main category that we're going to think about is going to be pulmonary. So different pulmonary causes of clubbing. Again, simple garden variety asthma does not give you clubbing, so we have to think about other things that might be going on that might give you chronic respiratory symptoms. On a child that comes in with clubbing, chronic respiratory symptoms, poor weight gain, histories of pneumonia, and respiratory infections and sinus infections, I think a major consideration is going to be cystic fibrosis. So cystic fibrosis, CF, is a major consideration in a child like this that is coming in with these type of chronic symptoms and found to have poor weight gain and clubbing. So cystic fibrosis, I think, is a major consideration on this child coming in with these symptoms. Other things that you might think about would be different types of immunodeficiencies. So he does have a history of ear infections, sinusitis, pneumonia, right? And now he's got the clubbing and he's got the poor weight gain. So you definitely think about different immunodeficiencies. So you might think about things like HIV and other acquired type of immunodeficiencies, right? Or you can have different congenital ones as well. And I think a big consideration on a 6-year-old would be common variable immunodeficiency. So this is the right age for a child with CVID to present with these recurrent infections, sinopulmonary infections, poor weight gain, clubbing. CVID, common variable immunodeficiency, I think is a major consideration. The other one to consider is going to be Wiskott-Aldrich Syndrome, right? So Wiskott-Aldrich Syndrome, I think, is another major consideration on a child coming in with chronic sinopulmonary infection. So with Wiskott-Aldrich Syndrome, you will have IgM deficiency, so that gives you the risk for otitis media, sinusitis, and pneumonias. In addition to that, you would have eczema and thrombocytopenia. So those are the 3 things that you typically get with Wiskott-Aldrich Syndrome. So the boards love to ask about that. So Wiskott-Aldrich Syndrome, IgM deficiency giving you the sinopulmonary infections, eczema, and thrombocytopenia. So something to consider in this child as well then as far as immunodeficiencies. Okay, so I think those are big categories you got to think about. Other things that you might consider kind of related to some of the immunodeficiency or cystic fibrosis type of issues would be some sort of ciliary issue, right? Some sort of desmodal cilia type of syndrome, right? So desmodal cilia. That you can have primary ciliary dyskinesia, right? So you can have that entity. So primary ciliary dyskinesia will present with chronic sinusitis and pneumonia and respiratory type of symptoms. So your cilia don't move as well, so you don't clear the mucus as well, so you're at risk for infections. That can cause that. And then if you have ciliary dyskinesia, but also have situs inversus, then you have to think about another syndrome called Cartagner syndrome, right? So that's another possibility as well. So Cartagner syndrome. which is basically desmodal cilia, along with situs inversus. That will be another consideration, but that's all related to having ciliary dyskinesia or desmodal cilia causing those type of issues. Other things that you might consider with chronic respiratory type of things would be alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin deficiency can also present with chronic lung infections and pneumonias and respiratory symptoms and clubbing, and those patients can also have liver involvement and increased LFTs and liver dysfunction as well. But alpha-1 antitrypsin deficiency can present with clubbing and chronic respiratory symptoms as well. So I think that's a consideration on this patient as well. And then you can have other things like interstitial pneumonitis. So interstitial pneumonitis can also give you clubbing and chronic respiratory symptoms. That would be another entity you could think about, or you can have something kind of anatomical and localized type of chronic infections that can then lead you to clubbing, like if you have like a pulmonary sequestration. So pulmonary sequestration would be another consideration, where again you would have you have a lung tissue that is not being perfused, so you have chronic infections in that area, and that can present with clubbing because of the chronic infections as well. And then other infections that you might think about, TB, tuberculosis, can present with clubbing as well. So chronic infections of the lung, so TB can do that as well, and even other infections like an abscess or an empyema can sometimes give you clubbing as well. So that would be another consideration. So an abscess or empyema can present with clubbing as well. And then a couple other entities that you have to think about. Something called ABPA, which is allergic bronchopulmonary aspergillosis. So allergic bronchopulmonary aspergillosis can also cause you to have clubbing. And basically what that is that aspergillus is a common fungus that is ubiquitous and that we're all commonly exposed to. And then when you have some underlying issue like asthma, like cystic fibrosis, like immunodeficiency, like desmodal cilia, you're not able to clear the aspergillus that gets into our airways, and then it causes a hypersensitivity type of response. So it's called allergic bronchopulmonary aspergillosis. So you mount a hypersensitivity response to the aspergillus that you're not clearing. So it's not a primary fungal infection, it's actually a kind of a hypersensitivity pneumonitis to the aspergillus, and because you have sticky mucosa and you can't clear your mucosa, you can't get rid of the aspergillus fungus, and it causes the hypersensitivity response. So you have some underlying issue that then predisposes you to ABPA. Now all of these things and all these chronic infections basically will lead to bronchiectasis. So basically anything that can lead you to have bronchiectasis can give you clubbing as well. And bronchiectasis just means you have dilatation of the bronchi because of chronic inflammation, chronic infections from any of these reasons, and then you get bronchiectasis. Now you can have idiopathic bronchiectasis, and that can cause clubbing as well, but usually bronchiectasis is secondary to some other process, and anything that gives you bronchiectasis can also give you clubbing as well then. So these are some of the pulmonary things that you would consider on a child coming in with clubbing and chronic respiratory symptoms as a cause of the poor growth and the chronic respiratory symptoms. So these are some of the things that you would initially think about from a cardiac perspective and a pulmonary perspective. And then beyond that, there's a couple other organ systems that you might think about as cause of clubbing as well. So the other organ system you might think about that can cause clubbing is GI tract. Now you wouldn't think GI tract, and why would that cause clubbing? And clubbing can actually be from just chronic inflammation as well. So a lot of this is from inflammation, but also this can cause hypoxia and cyanosis, and that can cause the clubbing. But any disease process that gives you chronic inflammation can also cause you to have clubbing as well. So from a GI perspective, things like inflammatory bowel disease, because of the chronic inflammation, can actually give you clubbing as well, and even things like celiac disease can give you clubbing, and then also any type of chronic liver disease can give you clubbing as well. So there's some GI things that you think about as well, and that's related to chronic inflammation, and that chronic inflammation can cause you to have the clubbing. So in that same line of thinking from chronic inflammation, a couple other things that you have to think about is you can have different malignancies that can give you clubbing as well. So things like lymphoma and chronic inflammation and things from lymphoma can give you clubbing as well. So that'd be kind of an oncology type of thing you might consider. And then you might think about other things like rheumatologic things that can give you clubbing as well, right? So lupus, JIA can also give you clubbing as well. So anything that gives you chronic inflammation can give you clubbing as well. And some of these, any of these could maybe give you chronic hypoxia as well if it involves the lungs, right? Lymphoma, if you have any type of compression of your airways and have hypoxia chronically from that, or any of the rheumatologic things where you get a serositis and a pleuritis and gives you interstitial lung disease or anything like that, that can give you chronic inflammation and therefore the clubbing as well. So these are some of the things that you consider on a child coming in with clubbing. So this is kind of the differential diagnosis on our child, on our 6-year-old that has chronic respiratory symptoms and quote-unquote poorly controlled asthma, difficult to control asthma, and then comes in and is noticed to have poor weight gain and also noticed to have clubbing. That really broadens differential, and it's not just simple asthma, and there's something else going on in addition to the asthma or separate from the asthma that is actually causing the clubbing and the poor weight gain. So this was our differential diagnosis on this patient when he first presented, and now let's talk about what the workup would be on a child coming in with these symptoms and how you would approach a child with these symptoms and where you would go as far as the workup to rule in and rule out some of these type of processes then. So this child, when he first came in, got a chest x-ray, and the chest x-ray did show bilateral infiltrates, especially of the lower lobes, where we were hearing the crackles. So because of the chronic respiratory symptoms he was having and the concern for pneumonia and other chronic issues, he ended up getting a CT of the chest. And the CT of the chest showed a couple of interesting findings that helped us maybe think about what might be going on. So on the CT of the chest, he had something called Tract sign, right? So CT of the chest had this Tract sign, which basically is kind of like railroads, where you see like the two rails of a railroad, and basically what that is a dilated bronchus, and you see a dilated bronchus, and you see the edges of the bronchus on the CT of the chest, and that's called the Tract sign. So kind of like a railroad or rail tracks that are parallel and that you see going, and that implies dilated bronchi or bronchiectasis. So that was one of the things that we saw on the CT of the chest. Also then the other thing we saw was a signet ring sign. Signet ring sign was another thing that we saw on the CT of the chest. And basically what that is that again, that shows bronchiectasis. So typically you don't see dilated bronchi on a chest CT, so you don't see the Tract sign. And the signet ring sign is where you have a dilated bronchus and the adjacent blood vessel right next to it. So usually you just see the blood vessel and you don't see a bronchus that's associated with that blood vessel. But in this situation, you would see a dilated blood vessel, a dilated bronchi, and then on top of it, you would see a kind of a blood vessel with the contrast going through it, so it almost looks like a ring. So it's called the signet ring sign, where you have a dilated bronchus next to and adjacent to the blood vessel. Normally, you would see blood vessels, but you would not see the bronchi being so dilated. So when you see this in this type of pattern, it's called the signet ring sign, and that also basically means that there is a bronchiectasis. So the CT of the chest basically confirmed that the child had bronchiectasis. So now the question was, does the child have primary bronchiectasis or idiopathic bronchiectasis, or is it secondary to some of these causes, all of which can cause bronchiectasis as well? So we needed a little bit further workup to help us decide that. So basically, he got some labs when he came in. He had a CBC and some immunoglobulins and a sweat test when he first was admitted because of his hypoxia. He was admitted to the hospital. So the CBC showed some eosinophilia. So his eosinophils were a little bit elevated. Normal eosinophil count should be less than 500, and his was closer to about maybe 800 or so, 800, 900. So it was a little bit elevated. So he had a little bit of eosinophilia, which you can see with asthma, you can see with eczema and being atopic, which he was. But that did catch our attention that he had some eosinophilia, but again, it could be consistent with his asthma and his eczema and being atopic and things. But that was something we found. His platelets are normal, so that helped us from a Wiskott-Aldrich Syndrome perspective, because usually you have thrombocytopenia, but that was normal. He had a sweat test to help rule out cystic fibrosis, and that came back negative. So a sweat test of less than 60 milliequivalents is considered a negative, and his was really low and negative. So above 60 is considered positive. A sweat chloride test considered positive, and then you can do further genetic testing to confirm cystic fibrosis, but the screen was negative for his sweat test. So that kind of helped us rule out or make cystic fibrosis much less likely. Then we set immunoglobulins, thinking, could he have a common variable immunodeficiency or something going on with that? And his immunoglobulins all came back normal except for his IgE level. His IgE level was high. It was in about the 1,000 or 1,100 range, which is high and abnormal. So now we had a child with eosinophilia, in addition to elevated IgE levels, with the bronchiectasis on CT, with the chronic weight loss or the poor weight gain, with chronic respiratory symptoms, and the hypoxia and the clubbing. So based on all that, we started to think about possibly allergic bronchopulmonary aspergillosis as a potential diagnosis, and we had some titer sent for aspergillus from his blood, and that came back elevated. That suggested that it was positive, so that suggested he had allergic bronchopulmonary aspergillosis. So that was the diagnosis that we made on this patient, was the ABPA, or the allergic bronchopulmonary aspergillosis. So again, it's basically, it's not a fungal infection. It's the aspergillus fungus that we all are exposed to. But because he did have bad asthma, and that allowed for mucus plugging and difficulty of clearance of the secretions, and then he wasn't able to clear the aspergillus, so he actually was mounting a hypersensitivity response to the aspergillus, and that's what caused him to have the chronic issues and the clubbing and things. Just a couple of points in general about clubbing. One of the common signs that you look for is called a Shamrock sign, right? The Shamrock sign is when you take your finger and you put your fingers together, and normally you would see a little bit of a space and kind of a diamond in the middle here, right? And that would be the Shamrock sign. So when you do not have clubbing, you would see that little diamond. But then when you do have clubbing, that diamond disappears because of the clubbing, and that's one way to confirm that a patient might have clubbing. So that's one thing to remember as well then. Okay, again, because our child had underlying asthma, but then because he had the or the elevated IgE syndrome, IgE levels, and he also had the eosinophilia, and he had positive titers to aspergillus, in addition to all his bronchiectasis and things, that helped us make that diagnosis. Now, to treat ABPA, steroids is usually the mainline treatment because it's a hypersensitivity response. So you usually treat with steroids, and it was interesting that over the last several months, our patient had been getting steroids for his asthma exacerbations, and that was actually probably helping to treat his ABPA and the inflammation and the hypersensitivity to the aspergillus. But then when he got stopped off the steroids, then he would have worsening of the symptoms. So basically you treat with steroids, and there's debate about the role of antifungals because it's not truly a fungal infection. But if you're having trouble clearing and eradicating the Aspergillus fungus, then some people will advocate for antifungals as well to help treat the fungal component of this and the cause of the hypersensitivity reaction. So definitely steroids, chronic steroids, and that you taper to help with hypersensitivity response and the inflammation, and potentially even antifungals as well to clear the fungus and the exposure to the Aspergillus that's causing these issues. So again, this is the differential diagnosis for a child coming in with clubbing, and a couple of take-home points. Simple garden variety asthma does not give you clubbing. So our child did have asthma as an underlying diagnosis, but he had, in addition to that, the ABPA that is what was causing him to have the clubbing and the poor weight gain. So when a child comes in with chronic respiratory symptoms but has clubbing and poor weight gain, think about other things as well. So something in addition to the asthma, or a different diagnosis like cystic fibrosis or an immunodeficiency, or something with their cilia, or something else going on. So I think that's an important consideration, because we see a lot of asthmatic patients, but make sure every time you see an asthmatic patient or a child with chronic respiratory issues, always check their growth and make sure that they don't have poor issues with poor weight gain, but also always check their fingers to make sure that they do not have clubbing, because if they have poor weight gain or clubbing, then be careful that that's not just simple garden variety asthma, and that there might be something else going on that you really have to consider or think about on that patient as well. Then, so this again is the differential diagnosis to think about in this type of a child, and again the goal of the CRASH course and the CRASH case is to kind of use your clinical reasoning skills to come up with a broad differential diagnosis. So I didn't go into a lot of details about each one of these, but you can use this case to further read about specifically some of these entities, but hopefully it gives you an idea how to approach a child with clubbing and the differential, and what you would think about and consider in that type of a patient. So hopefully this was an educational case, and we look forward to seeing you at future CRASH cases as well.